Yep.
Okay, can you see my screen? Okay, so today we are going to talk about kidney disease. Kidney disease is a problem all over the world. I am thinking about how big is the problem in Timor. Visited HNGV and there was a dialysis unit in HNGV, and they have a few beds there to do dialysis, and that was the only unit for dialysis in the whole of Timor-Leste. Okay, so I understand that they were going to develop that unit. I also wonder whether there are facilities for peritoneal dialysis. Any idea?
Which one, Doctor?
Peritoneal dialysis.
Sorry, you're asking which one is available here, is it?
Do you know whether there's peritoneal dialysis available?
I haven't heard of anybody with peritoneal dialysis. Yeah.
I know hemodialysis is available.
Yeah.
Right. With the current logistics in Timor-Leste. So, but in the future, it should be developed within the country. Yeah, if not, it'll be very difficult moving forward as the population gets older and more people need dialysis. Okay, I thought I'd just start off with what are the common causes of kidney failure. So I try to pick the ones that would be more important for Timor-Leste. So we can divide the causes into, firstly, the congenital causes. And from pediatrics, usually they talk about, especially for the males, whether they have posterior urethral valve. Okay, this posterior urethral valve actually is something that's seen in pediatrics. It actually causes more urinary tract infections, especially in the boys. And over time, it causes scarring of the kidneys, and it is one of the main causes of undiagnosed kidney failure, okay, especially in the children. Then you have adult polycystic kidney disease, which is overall very rare, okay, but I'm sure there are a few in Timor-Leste, and these are probably the ones that are currently on the dialysis. Okay, and of course you have things like infection. Infection can be a urine tract infection. It can be a kidney infection, which we call pyelonephritis. It can be due to inflammation of the kidneys, usually due to a immune-mediated response. Okay, we call it acute tubular necrosis. And what we have learned so far is chronic disease. Okay, if you have hypertension not controlled, or diabetes not controlled, or even high cholesterol and vascular disease not controlled, it can lead you to have kidney failure when you're older. Okay, it can be due to obstruction, so any form of urinary tract obstruction, or even things like stones, okay, calculi, renal calculi, bladder calculi that causes obstruction. It can actually cause backflow into the kidneys, hydronephrosis, and it can cause kidney failure. Vascular causes, so anything that obstructs the renal artery, okay, commonly it will be renal artery stenosis. Also, if you have a abdominal aortic aneurysm that dissects into the renal artery, it can cause obstruction and it can cause acute renal failure. And of course, you have things like iatrogenic causes. Okay, so if you do a CT scan with contrast, there's a chance that you will cause damage to kidneys and medications. At this point, can I ask, what are the common medications that can cause kidney failure? Oh, hi, I think we have more people in now. Hi, Dr. Jokina, Dr. Rita.
Yep, Dr. Sophia, Dr. Zizelda, and are together with Dr. Jokina. So hooray.
I see. Hello, everyone. Nice to see all of you again. So just a quick question. Hello.
How are you?
Yes.
Okay.
Okay. Nice to see all of you again. Yeah. Okay, the question. What are the medicines that you know that cause damage to the kidneys? Okay, what we call nephrotoxicity. Anybody?
Aminoglycoside.
Very good. Okay, so aminoglycosides, which are antibiotics, okay, things like gentamicin, okay, can cause damage to the kidneys. Okay, so be careful when you use. Do look out for kidney injury. What else? Another example that can cause damage to the kidneys. Okay, very commonly used for pain. What are some of the medicines that we use for pain that can cause damage to the kidneys? Okay, so gentamicin, I think Marcelo has put in gentamicin, very good. One more, anybody? How about ibuprofen?
Ibuprofen.
Sorry, can you say that again? Sorry, I didn't quite catch. Yes? Okay. Okay, so yes, so NSAID, very good. Okay, so Marcelo says NSAIDs. Yes, okay, all of the NSAIDs can cause damage to the kidneys. Okay, Jokina has
Dr. Linus, somebody asked spironolactone, yeah?
Spironolactone, yeah. Spironolactone is a diuretic, okay, so it doesn't cause damage to the kidneys. Usually, okay, but in cases that let's say the kidneys are not working so well anymore, it can cause the kidney function sometimes to worsen due to dehydration. All right, so yes and no. Usually we don't consider that as dangerous to the kidneys. Okay, can we move on? I've actually put in a list here. I can't access it now because I'm on a secure computer, but I will send out the slides. Okay, you can refer to this list for a whole list of medicines that can damage the kidneys. Okay, even common things like paracetamol, sometimes, very rarely, can actually cause damage to the kidneys. Okay, and then it actually puts in the mechanism of how it causes damage to the kidneys. Okay, so do refer to that list. Okay, next slide. Okay, how do we calculate the renal function or the kidney function? Okay, usually we look at the clearance of this solute called creatinine. Okay, creatinine is a breakdown product. The common formula that we use is the Cockcroft-Gault equation. So I'm sure you must have learned this in your medical school. It's very common. They used to ask us to calculate it. Nowadays, there are a lot of calculators on the internet, okay? Or you may have some apps that can help you to calculate, okay? So this is the common one that we use as the gold standard. But recently, in more practical terms, we use MDRD formula, okay, and that comes out as something we call the EGFR, which is the estimated glomerular filtration rate, okay, and it's calculated for you. Okay, there's a recent update to this that uses a CKD EPI equation, also under MDRD. Okay, just a very technical details, and I'm sure all of us cannot calculate things like this, okay, to the power of negative 1.154 and all that. Okay, so basically the calculator will calculate it for you. Okay, the laboratory will calculate it for you. But just to help us to understand, what is the difference between the Cockcroft Gault and the MDRD? Actually, the difference is here, okay, in the mass in kilograms. So the Cockcroft Gault actually uses the patient's mass, okay, in kilograms, the weight of the patient, to calculate the creatinine clearance. So you have someone that is very big size, okay, or compared to someone who's very small size, they will take the size into consideration when they do the calculation. Whereas in the EGFR, they do not have the mass. They take it as a standard, okay, 63 kilogram person who is 1.7 meters tall. Okay, now we look among all of you. How many of you are 63 kilograms and 1.7 meters tall? Okay, so that is the difference in the calculators. Okay, both are accepted internationally. Both give a good estimate of the kidney function, but based on the mass, you might actually get a different reading. Okay, what are the stages? Usually we divide them into stage 1 to stage 5. Usually when you're in stage 4, you can consider dialysis already because a lot of the functions of the kidney are not working. Okay. If you use the different calculators, you may have different readings for sometimes if you use EGFR, you may get stage 2. If you use Cockcroft Gault, you may get stage 3, but you will still get a good idea of the range. Okay, of the rough stage of the kidney disease of the patient. And so how do we estimate the kind of damage that is happening to the kidneys? Okay, usually we will check for protein coming out in the kidneys. Okay, that's why there's this picture here. Usually if there's a lot of protein, you will see a lot of bubbles. Okay, so some patients may come to you and say, oh dear doctor, my urine has a lot of bubbles inside. What may be the problem? Okay, and usually we will have to look for protein in the urine. Okay, it could be a sign of protein in the urine. Okay, over here we commonly use dipstick to test for presence of protein. If you send it to the laboratory, they would spin it down and check for trace amount of I put on here nephrotic syndrome versus nephritic syndrome. This is the overall syndromes that we learn when we learn about pediatrics in the past, and it really corresponds to different modes of injury to the kidney. Okay, so nephrotic syndrome is really where the kidney starts leaking a big amount of protein, and that causes the damage to the kidneys. Okay, whereas nephritic syndrome is usually denotes some form of inflammation to the kidneys, and it comes with all the other things like high blood pressure, hematuria and things like that also. So okay, so just to understand, both can cause damage to the kidneys. Okay, and they come in different syndromes in general. If you lose a lot of protein, you can cause anasaka. Okay, anasaka is a term that we use to talk about swelling in the third space all over the body, including the periorbital regions, including everywhere that is dependent, so everywhere that is lying down, based on gravity. Even the stomach can cause ascites, can cause pleural effusions in the lung, can cause pedal edema as well. Okay, if you have low protein in the body. Okay, so protein is a marker of kidney damage. And how do we treat this? The current treatment that we have is this. Okay, so the ACE inhibitors, the angiotensin receptor blockers, as well as the most recent type of medicine is used for diabetes. It's not available in Timor-Leste yet, but in time it will be available. Okay, so SGLT2s is something that we use in the just also to protect the kidneys based on current evidence. Okay, as mentioned just now, talking about Anasaka, if somebody has kidney problems or kidney failure, especially in severe stage 4 to stage 5, they would tend to have what we call fluid overload. Okay, it's a term that we use to describe a lot of water in the third space in the body. Okay, so as in this diagram here, most of the time it comes out in the both feet. Okay, so swelling in the ankles and the legs, you have pitting edema. Pitting edema. Okay, pitting edema meaning when you actually compress on the area with a thumb or a finger, it will depress in. Okay, after that it will come out again. The skin will come out. Okay, you can have ascites, you can have pleural effusion. Okay, and just put in here the difference between left heart failure and right heart failure. Okay, usually if the left side of the heart fails, you will have pulmonary edema, and the symptoms will be autopnea and paroxysmal nocturnal dyspnea. Okay, breathlessness when lying down, and waking up in the middle with severe breathlessness. Now, if the right side of the heart is the one that is in failure, then that's where you cause all your dependent edema, your ascites, as well as the swelling in the legs. Okay, so just to be a bit more technical about it, there's a difference between the failure of the left side of the heart and the failure of the right side of the heart, right? And both can be caused by fluid overload and can be caused by kidney failure. Okay, and the treatment for this really is to give diuretics, restrict the water intake over the course of the day, to elevate the part that is swollen, and also to move, exercise, or ambulate, right? And this usually acts as a muscle pump to pump the excess fluid out of the area. Any questions?
No question, Doctor.
Okay. You can also type the questions, any questions along the way in the chat box. We can answer questions after this. Okay, now moving on. Kidney failure causes problems with electrolytes. Okay, and I've listed down here some of the electrolytes that may be either too high or too low. Okay, so most importantly and deadly, it is the hyperkalemia. Okay, high potassium. Now in renal failure, this is the one that goes up, and potentially if this is too high, it can cause a cardiac arrhythmia and the patient can die from this. Okay, so we see those stage 5 kidney failure patients who are not keen for dialysis or not able to get dialysis. A lot of times their potassium is very high. Okay, and at any point, their hearts may go into an irregular rhythm and they can die suddenly, okay, from sudden cardiac arrest. Okay, now it also causes high phosphate, okay, and that's why a lot of times we give phosphate binders. Okay, phosphate can also affect the potassium levels in the blood. It can cause low or high sodium. Okay, kidney failure can cause low or high sodium, okay, depending on whether it causes you to be dehydrated or it causes you to be fluid overloaded. It can cause acidosis. Okay, so especially if you have kidney failure and you have another infection, okay, the rate of acid buildup in your blood is very fast. Okay, and you can go into metabolic acidosis and you can fall really sick. Okay, it also causes low calcium, right? So because the kidney is so important in the keeping a balance of the electrolytes in our bloodstream, when the kidney fails, the balance is imbalanced. Okay, there's no balance, and this is why the blood will have too much of some electrolytes and too little of other electrolytes. And some other problem, unhappy bone, okay, very diseased bone. Kidney failure, especially stage 4 and 5, you get what we call renal bone disease. Okay, actually it's similar to osteoporosis, but we call it in a different term because the mechanism is different. Okay, so bone disease is very common in kidney failure patients, and when they fall down, they're more easy to fracture, to get a fracture, okay, of their bones. Kidney failure can also cause anemia. Okay, usually it's because of the lack of the hormone that is produced by the kidney, which is called erythropoietin. Okay, erythropoietin is a hormone that is secreted by the kidney that stimulates the bone marrow to produce blood. Okay, in kidney failure, the erythropoietin is also low, and a lot of the patients who are on stage 4 or stage 5 kidney failure have to have an external injection of erythropoietin regularly. It causes uremia, the buildup of urea toxic products in the blood. Okay, and this causes a lot of problems. It causes uremia, causes nausea. Uremia causes pruritus, itchiness. Uremia causes confusion, okay, in the brain. It causes confusion, altered mental state. It causes lethargy, okay. It causes anorexia, okay. It causes increased risk of having gastric ulcers. Okay, so uremia is a big problem, and a lot of patients who are in end-stage kidney disease, patients at the end of life due to advanced kidney disease, actually a lot of their symptoms are due to uremia. Okay, so at end of life, a lot of the symptoms are due to uremia. And lastly, but not least, it causes malnutrition. Okay, a lot of times due to the anorexia and nausea. Okay, causing there to be difficulty in eating, and of course the kidney is also important in the synthesis of some of the vitamins, especially vitamin D. Okay, dialysis. So before a lot of you came in, we were asking the question about is dialysis available in Timor-Leste? So yes, there is hemodialysis in Timor-Leste, in HNGV. I think that's the only center in Timor-Leste that does hemodialysis. Okay, and usually the patients have to go there twice a week, or maybe even 3 times a week, to take their to have their hemodialysis. Okay, when we visited the when we were in Timor-Leste a couple of months ago, there were plans to expand that unit to more beds. Okay, but usually by the time the patient needs hemodialysis, is a big resource. It causes a lot of time and money and effort, you know, to go regularly to the center just for the dialysis. Okay, so it's expensive. It causes resource. Okay, it's also painful. Okay, for the patients, but a lot of them after the dialysis they feel so much better. Okay, and we talk about peritoneal dialysis. So peritoneal dialysis is challenging. Okay, you actually need many boxes of packets of the solute for peritoneal dialysis. Basically, you run the solute right into the peritoneal cavity of the patient, and the peritoneal cavity, the abdominal cavity, actually acts as the dialysis medium. Okay, so it is very special. It done well, the patients actually can do it at home, and but they need a lot of these bags, which I understand is not available currently in Timor-Leste. And the last but not least is the kidney transplant. Okay, wow. Yeah, have a look at this. It's a kidney. Do you know a kidney looks like this? Does it look healthy? Not too bad, not too bad. Okay, the color is a little bit dusky, but this is the usual kind of color. Okay, for you who have done surgery, this is usually how it looks like. Okay, yes, it's small. It's about the size of the palm of the hand. Okay, and usually with a kidney transplant, it's a new lease of life for a lot of the patients. Okay, it is fantastic. Okay, to have a kidney transplant. A lot of them can live longer with a kidney transplant. They can pass urine again, and a lot of them can live fairly normal lives. Okay, but it's a very specialized area of field. Okay, you need multidisciplinary care. You need the kidney specialist. You need the urology surgical specialist. You need a transplant specialist. You need a immunologist expert, okay, who is able to suppress the particular parts of the immune system, okay, and yet help the patient to be able to have a fairly normal immune system otherwise to fight the other common diseases. Okay, this is my last slide before I go into the MCQ that we did, the pre-test. So yes, kidney, like any other organ, when it fails, we do need to do care planning. What is care planning for? It is got to do with what kind of support that we want for the organ that has failed. Okay, so how do we support in terms of sending a patient for dialysis? When do we think we can withdraw the dialysis? Okay, is it ethical or not ethical to withdraw dialysis if there's no resources? Okay, who's going to send the patient for dialysis? Any transport that needs to be arranged? Okay, what is the extent of care? If let's say the kidney starts to fail even on dialysis, how far do we want to go? Okay, if patient is on dialysis, and the patient falls ill, do we send to the intensive care unit, the ICU? Who's going to pay and for how long? And when you reach the end of life, what are your priorities going to be? Okay, do you want to be among family members? Do you want to be back in the village? Do you want to be in a hospital, for example? Okay, these are the things that we need to talk through with the patients. Right, it's about the same as the kind of counseling you do for the HIV clinics, the TB clinics. Okay, you do need to talk through a lot of these to help the patient to understand their disease and to help them to understand and make decisions for the future. Okay, now we go to the pre-test, the question. So I took this from this morning. Okay, so if some of you have answered the question since then, it won't be reflected here. Okay, but you would know your answer as well. Okay, so first question, which of this is not a complication of kidney disease? Okay, so bone disease is a complication, anemia is a complication, pedal edema is also a complication, okay, and high potassium is also a complication. Okay, so ischemic heart disease in itself, okay, narrowing of the blood vessels causing lack of blood flow to the heart, causing your heart attack, that in itself is not a complication of kidney disease. Okay, so the answer is ischemic heart disease. Question 2, which of the following is part of a renal diet? and you can choose multiple options. So if the patient has kidney failure or kidney disease, usually we put them on a kidney-friendly diet or renal diet. We advise them to eat low salt. Okay, so low salt is important for kidney diet to control the hypertension, as well as it also helps to prevent the progression of the kidney condition. Okay, in kidney patients, if you give too much salt to them, they get fluid overload. Okay, so that's the reason why you give low salt. Low protein, yes. Okay, because if you give a high protein diet, it is said to cause more damage to the kidneys, to help to make the kidneys, the progression of the kidney disease faster. Now, the other three questions the other three options are actually wrong. So, the low sugar, okay, we do advise low sugar for patients on who have diabetes to control their diabetes well, but technically it's not a component of the renal diet. Okay, it's a component of diabetic diet. Okay, now high protein, of course, we don't advise high protein for patients on renal diet. And high calcium, we don't necessarily need them to be on high calcium. They just need to have a normal calcium diet, okay, adequate calcium. Okay, so the symptoms of end-stage kidney disease are the below except. So so all of these are true except limb weakness. Okay, so kidney disease causes anorexia, it causes pruritus, it causes anuria, lack of urine, it causes lethargy. Okay, but it's not supposed to cause limb weakness. Now, what is the cause of limb weakness? It's another cause, okay? Right. Next question, what is calcium acetate used for in the treatment of kidney failure? Okay, it is not to prevent renal bone disease. It is not to reduce the magnesium levels in the blood, and it's not to reduce lactose intolerance. Okay, it is actually to reduce the absorption of phosphate in the diet so that the patient doesn't have high phosphate, hyperphosphatemia. Okay, very good. Everyone got it correct. Which type of dialysis is more suitable in a patient with history of ischemic heart disease? Correct, it's peritoneal dialysis. Okay, so just for your information, hemodialysis actually causes a lot of stress on the cardiovascular system. So a lot of them do end up having vascular complications, and it may make the ischemic heart disease worse. Okay, I think this is the last question. Mr. Rao has a kidney and heart failure and is on 80 milligrams a day of furosemide. He presents with worsening water retention in his limbs, so fluid overload. He is still, okay, I think there's a problem with the question. Okay, so basically, what are your options? Choose all your possible options. Okay, so yes, you could increase the dose of furosemide. Actually, you can also change to this other medicine that is stronger than furosemide. So it's called bumetanide. It's supposed to be about 40 times as strong as furosemide. Okay, so it's also a loop diuretic, so you could change it to bumetanide, which is supposed to be stronger. We call it synergist, okay, to the loop diuretic. It's called metolazone, and you could also add another diuretic called spironolactone. Okay, but amlodipine doesn't reduce the fluid overload. Okay. Yes, I come to the end of my presentation. Shall we have a time of question and answer? Any questions you have?
Yeah, I have a question, Linus. So in your experience, some of the patients that we see with kidney disease have also got nutrition problems, especially in our context. So in terms of low protein, how much would you emphasize that aspect of low protein diet, given that some of these people already may not have enough protein in their diet? How do you make a decision? I know it's a complicated question, but can you give any advice on how we should think about that kind of or about that kind of clinical context, especially for the TB patients and the RHD patients?
Yeah, thanks, Louis, for the question. I think it's a very good question. There is a recommended amount of protein intake per day, okay, for kidney diet. So I think it's about 4 grams or 8 grams. It's something like that. I will need to check that up. So, but there is a recommended daily amount of protein that somebody who has kidney failure should actually be taking. So very good question. A lot of people in Timor-Leste may be more on the malnourished side, okay, especially if you find some of them from the rural areas, okay. Of course, people in Delhi tend to be a bit more fat, so the problem of malnutrition is not as much, okay. So it is a balance. Generally, the protein intake, I imagine, comes from chicken, fish, soy products, okay, like the tofu and all that. Milk, possibly. Yeah, so these are the things that that you have to ask the patient, and maybe to try and make sure that it's probably about 2 servings of protein per day. Okay, not anything more than that.
Thank you.
Okay, thank you. Good question.
Ini perguntas serasa si Doktora Marita, Doktora Joaquina, Doktora Sofia, Doktora Zizelda, Dr. Marcelo lagi.
Nada, Mount Marcelo.
Yeah. Okay. I know it's nearing the end of your lunch break, Linus. So I am keen to let you go. Last chance for anybody to ask questions. Doktora Joaquina has just asked a question. She said, Doktora ita husu kona ba paciente sira nebe atu labele han protein ga? Is that your question? Are you asking which patients should avoid protein? Is that what Doktora is asking?
Okay, so usually, so good question. I also think also the question is which stage of the kidney disease should you advise the patient to avoid protein? This is usually at the end stages. Okay, it's the most important. So usually at stage 3 to 4 to 5, you can actually advise the patient to avoid protein. It's really a fine balance, okay, because especially the patients who have a high degree of proteinuria, okay, who have nephrotic syndrome, whose kidneys are actually leaking a lot of protein. A lot of times their protein level in the blood is very low. Okay, as I presented just now, they may have anasaka. Okay, and the albumin levels can be really low, okay, like 20 or less than 20. And these patients, you know, you actually have to give more protein, but the more protein that you give, you actually might end up damaging the kidneys more. So it's actually both ways are also not so good. It's a fine balance. I think a lot of times a dietitian or a nutritional specialist should get involved, okay, to see what is the daily intake of the protein and what is the level of the proteinuria, okay, and what level shall we advise in order to make there be enough protein so that you don't end up having malnutrition. And then you also try to protect the kidneys at the same time. So yeah, it's a very good question. I don't have a clear answer. Okay, I would say that you should advise patients to have enough protein, and yet not have too much protein that makes you damage the kidneys more.
In your own practice, Linus, have you seen patients who you think have had worse kidney outcome because of too much protein in their diet?
It's actually not so common, okay, and I would imagine in Timor-Leste it will be even less common, okay, because like what Dr. Lewis has mentioned just now, I think a lot of patients in Timor-Leste actually have eat less than the recommended amount of protein.
Yeah. So I think it sounds like for us, it's good for us to know that we have to be careful about the diet for our patients with kidney disease. But we also have to emphasize on perhaps on the potassium parts of the diet, maybe most importantly, maybe for all of us, we need to ask patients what they are eating carefully, and then also learn a little bit more about nutrition and about the diet if there's no nutritionist around. Although actually next time our colleagues from nutrition, maybe they can join us and we can learn together.
Yes. Certainly.
Yeah. Okay. Time is 1:50, and I like that question from Dr. Joaquina. Is there any other question from anybody else? Dr. Merita, Dr. Sofia, Dr. Zelda, Dr. Jennifer, Karik, iha perguntas? Kuna ba ito ni?
Lahir, Doktora.
Okay. Então, obrigado, Wayne, Dr. Linus. Thanks a lot for your time today, and we look forward to hearing from you again soon for the next clinical topic. Please give me your feedback, everybody, if you found the session helpful, if you found any parts of it that you want to request more of, less of, just send it to me, and we'll continue to try to bring you more helpful sessions for CPD, Medical Dental in Maluku Timor. Thank you everybody for your time today. I'm going to end this meeting here. So, obrigada, bom fim de semana to everybody. Bye-bye.